Hello and welcome to today's webinar, The Benefits of Adding Radial Shockwave Therapy to Your Practice. This webinar is presented by Zimmer MedizinSystems. I'm Regina West, and I'll be moderating the webinar today. During the presentation, you may submit questions by typing them in the Questions tab on your webinar control panel. If there's time following today's presentation, we may be able to cover those questions during the webcast. If there's not enough time remaining for Q&A, answers to your questions will be emailed to you. Today's webinar panelists, Dr. Jay Spector and Paul Cummings, may briefly contribute information following today's presentation. I'd now like to introduce the speaker for today's webinar, Dr. Brian Fullem. Dr. Fullem is board certified in foot surgery with specialization in tendon injuries, including the use of extracorporeal shockwave therapy. He has experienced tremendous success using shockwave therapy for injuries. Dr. Fullem is a fellow of the AAPSM and is the scientific director for the AAPSM Annual Medical Conference. He has published extensively, including a national running magazine, chapters for textbooks, and his own book, The Runner's Guide to Healthy Feet and Ankles. His practice, Elite Sports Podiatry, is located in Clearwater, Florida, and specializes in treating athletes of all ages and abilities. Welcome again, everyone. Dr. Fullem, thank you very much for being with us today.
Thank you, Regina.
I'll now give you control of the presentation, the benefits of adding radial shockwave therapy to your practice. And in a moment, we should be able to see your screen.
All right, thanks everybody for joining. It's even cold here in Florida. It was 40-something degrees last night, so anyone that's where it's cold, I can feel your pain, although not really. So I'm in private practice in Clearwater, Florida. I practiced in Connecticut for 20 years, and then we moved here about 10 years ago. And the name of my practice is Elite Sports Podiatry, and I practice according to Dr. George Sheehan's statement that everyone's an athlete. Some of us should start in training yet. And we're going to talk about the benefits of radial shockwave. There's also focus shockwave, but for tonight, we're mainly going to be concentrating on radial shockwave. I thought we'd start with just a little history of shockwave. Patients often hear the term shockwave and they think of electric shock therapy of the brain. And part of the reason it's called shockwave therapy is that when they first discovered it in 1966 at the Dornier Company, someone touched the plate at the moment the projectile hit it, and he felt what he said was an electric shock throughout the body. And we know there's no electricity present, but they started to call it shockwave, I think, mainly from there. And the first use of it in the body was called lithotripsy. And it was treatment of kidney stones, and then it started to be applied in the foot in the beginning, mainly for plantar fasciitis. And I was an early adopter. I started using it in the early 90s, and United Shockwave Technologies would bring in that huge unit into your office, and it was one treatment. And you had to numb up the whole foot, but with an ankle block, and it did work pretty well. The advances have been great, and now you can have a unit in your office and you don't need to use local anesthesia. And we used to tell people they couldn't do anything for 6 weeks, and that's not true. You can get shockwave done and run that day. And this is a great website. It's the home of the International Society for Medical Shockwave Therapy. It has a lot of the latest journal articles and references on there, and a lot of information about shockwave therapy. So how does shockwave therapy work? The main way that we know that it works is via neovascularization. So new blood vessels get developed, and in an area like the plantar fascia, we know that the blood supply is poor. So that new blood vessels that come in there help to heal the tissue. It also depletes substance P, which is a neurotransmitter. And from the actual physical point of view of a shockwave, of how it's generated, we know it's a pressure wave actually. So what happens is the shock is produced within the handpiece with a radial unit. There's a tapping effect, and the sound wave goes into the tissue, and it helps stimulate that healing. Local anesthesia has actually been shown to reduce efficacy of it, so we want to try to avoid local anesthesia. And one of the other things that we found is higher total shockwave energies are associated with greater pain reduction. So some of this is from a great article by Schmitz, which was in the British Medical Journal, and I have that reference coming up in one of the slides. But this slide just talks about the working principle of shockwave technology, and the top part talks about focused shockwave. So that's a little bit more complex. Those machines are a little bit more technologically advanced, so they're much more expensive, in the $50,000 range. I know the Radial M-Pulse from Zimmer costs about $19,000, so much more affordable, especially with a payment plan. But the way it works is that if you look at that bottom picture, most of the hand pieces for the radial units are shaped like a gun, and there's a projectile or air that will produce a tapping effect at the head, and that tapping effect helps create the sound wave. The focused unit is more advanced in that the sound wave is actually produced in the handpiece and then transmitted into the body. So what we find is that, especially in the foot, we don't need to really go beyond radial typically to get enough of an effect. So this is a great schematic as well that shows, and the important point that we're looking at is that point of maximum energy flux density. So that's where you're going to have the most effective treatment from the unit. And you can see on the left-hand slide, the focused shockwave unit, the point of maximum energy flux density is fairly far away from the handpiece, sometimes up to 50 millimeters deeper. And in the radial, it's right underneath the handpiece. And most of the things we're treating, such as plantar fasciitis and any sort of the tendon injuries that it'll work well with, are pretty close to the surface of the skin. So that point of maximum energy flux density is close to the handpiece, and we don't really need to go much deeper than that. These are some of the statements and conclusions that Schmitz made in his article, which was published in the British Medical Journal in November 2015. And it's a free article. If you go on PubMed, you can read the entire article. And they looked in the PED-Pro database, and what they found was that all of the randomized controlled trials showed the following conclusions. The first two, that it's effective and safe. The other one that I think is interesting is number 3, that shockwave therapy, it was the predominant type listed and obtained the highest PED-Pro scores among all investigative treatment modalities. So what number 3 is saying is that there is not a better treatment than shockwave for most of the soft tissue disorders that we treat. I highlighted number 7. There's no scientific evidence in favor of either radial shockwave therapy or focused shockwave therapy with respect to treatment outcome, according to those randomized controlled trials. The distinction now should be termed radial and focused. So sometimes we hear the terms low energy and high energy. They really shouldn't be used anymore, but focused was sometimes associated with high energy and radial was sometimes associated with low energy, but there are some radial units that can produce a high energy shockwave. So the terminology I think is important to be using radial and focused instead of low and high energy. And number 10, I'm not so sure about. Most of the randomized controlled trials do 3 treatments spaced a week apart with 2,000 impulses. And I participated in an FDA study to get another machine approved in 2006. And we used the same protocol. And I think if you look back at the beginning, the first protocols were that using those parameters. I know some doctors like Rich Boucher in Seattle is doing 5,000 shocks on people. I typically do 3,000 shocks on most of my patients with the radial unit. And a lot of times I'll do 5 treatments spaced a week apart. So I think you can play around with that a little bit and see what works best for you. But I think one important point to make is that shockwave actually heals the tissue. So in this study, they did MRIs before and after treatment. And one of the things they found was, besides significant pain reduction, the MRI showed that the fascia went back to normal thickness. So that's one of the things we know when we get an MRI of someone with plantar fasciitis, is that fascia can sometimes be thickened up to 5 times thicker than what is normal. This particular picture shows a tear, and it can be effective in helping to heal tears as well. But I think that's an important thing to understand. Different than cortisone. Cortisone is not necessarily healing the tissue. Certainly it can be effective for something like heel pain, and I still do cortisone shots sometimes. But I think, what I always explain to my patients is shockwave is going to be better for long term because I think it's actually healing the tissue, whereas cortisone is sometimes better for short term because it does take a little bit of time for that effect to happen. And that's a closer picture of the one of the new Zimmer machines, the Impulse, and it comes with two handpieces, and it comes in handy sometimes because if you use that handpiece on 2 or 3 patients in a row, that the head of it will actually start to become hot. So, you know, alternating between the 2 units, and some days I'll have 5 or 6 people that are getting shockwave done. So having those 2 handpieces is a benefit and an advantage. And that goes over the current technology again. And the radial devices, you know, are in that range, and the Impulse is actually at the lower end of that. And the Focus devices, you know, started at around 50,000. So ideally, the great thing about it, I think, especially if you're treating an athletic population, is there's no downtime. I've treated athletes and they've run that day after getting shockwave done. Typically, I think it's better not to use NSAIDs. Some people think that can affect how the mechanism of action happens with the shockwave, but there's really relatively few contraindications to the treatment. You don't want to do focused shockwave over the lungs, and certainly that's a little bit out of our scope anyways, as people who treat the lower extremity. So I think that that's another important thing to consider is that there really are no contraindications for it. I'll treat diabetics, I'll treat people that are on blood thinners, and I haven't had any issues outside of a little bit of bruising. So it can be used for a significant number of problems as well. So this was a study that's being done in China, it's ongoing, and they've been finding that there is possible benefit for treating diabetic neuropathy. Certainly out of our scope, but erectile dysfunction is something that can be from vascular causes, and it's helping to produce new blood flow. The Achilles is an area that I find that shockwave can work extremely well, and especially the radial shockwave. When people have Achilles tendinopathy, typically it's not going to be in a pinpoint spot. The focus units are painful if you move the unit. So typically if you're using a focus unit, you want to put it in one spot and leave it there. That's one of the benefits of radial, is that you can move the device and move the handpiece up and down over the Achilles where the problem is. And when I'm treating the Achilles, I'm going to treat it in right down the middle, and then I'm going to actually go medial and lateral and treat it from each side. And if there is a spot that's a little more painful, I'm going to typically concentrate a little bit more on that area. So it's not like ultrasound where you have to keep moving the handpiece. You can put it in one spot and leave it in one spot. But if you're treating a greater area, then you can still move it. So these are a couple of studies, and the one by Dr. Saxena that was in the Journal of Foot and Ankle Surgery was done with a radial unit. It was a level 3 study, and he found that 78% of the patients in that study got better from radial shockwave therapy. ROMP is another name that you'll see a significant amount of the time when you research the shockwave literature, and he did a couple of great studies comparing eccentric loading versus shockwave and then combining the two. And what he found was the combination of the two worked better than either one alone. Both are effective. We know that the eccentrics are effective. We know that the shockwave is effective. Combining the two of them can actually make it a little bit more effective. Rasmussen did another study where he compared shockwave with placebo, and it was a level 1 study from 2008, and he found that the people who were in the treatment group got better in a statistically significant manner. Furia did a focused shockwave and found the same thing. Radial shockwave versus traditional conservative treatment, stretching and icing and gradual return to activity, much better outcome with the shockwave therapy. So this is how I have my patients do their eccentric exercises now. So the original idea of doing eccentric loading was to have your heel go negative, doing it off a step. I've actually had a few patients that develop problems from going down too low off the step or being too aggressive. One patient in particular came in to see me. We started doing shockwave on him. He had Achilles tendinopathy. After 1 or 2 treatments, when his symptoms started to go down a little bit, I had him introduce the eccentric loading, and I had him do it off a step. I told him to start with 10. Came back the next week, and his peroneals were all blown up because he did about 100 of them the first time. So doing it on flat ground, you can get the same effect. So what I tell my patients to do, up with 2, lift 1 foot in the air, try to slowly raise down on the affected side. And before I progress to the eccentric, I have them do do it with both feet. And then I'll progress to 1 foot. And I typically will start with 1 set of 20 and try to progress them to 3 sets of 20 over a 2 to 3 week period. So I think adding more than just the shockwave is important as well. It's a part of our treatment plan. It's not going to be the only thing we're going to do. This was a patient of mine who was a military, she's in the military. So military people, they're athletes. And she in particular was a college basketball player. So she enjoyed playing basketball. She liked to run. And you can see that right Achilles, the thickening of it. So we did 5 treatments with the Zimmer Impulse. And by the 3rd treatment, her Achilles had actually started that thickening had started to go down, and it was fairly normal appearing. By the 5th treatment, she was relatively pain-free. I don't typically expect that. What I always tell people is it's going to take at least 6 weeks after we finish the treatment before we're going to say this is working or it's not working. And I think the important thing with when you're treating people with shockwave is to underpromise, okay? Because you will end up having happier patients if their expectations are the same as ours. And one mistake that I made in the beginning was not informing my patients of that. And I had some patients where they'd come and they get 1 treatment and they call up and say, this isn't working, I'm not coming back. So I emphasize over and over again that how important it is, and I have a handout as well, and I emphasize that it's going to take some time. Be patient. And I'll tell people you want to give it up to 12 weeks before you say this isn't or isn't working. One area I found it to be extremely successful, and it's been studied in a few places, is with medial tibial stress syndrome. So this was another study by Romp using a radial device, and he compared a home training program combined with radial shockwave versus a home training program only. And the shockwave group significantly outperformed the other group. And it was 3 treatments with a radial device at 2.5 bar. And you can see the statistically significant improvement of them. This is a great article if you want to go back and read some of what a great proposal of how medial tibial stress syndrome works from Dr. Rich Boucher. Dr. Boucher has a great approach to it. And I try to incorporate his approach. And I think that one of the good takeaways from Rich's study here is that he calls it a tibial fasciitis. So the posterior tib and the soleus are the 2 muscles that are typically implicated in medial tibial stress syndrome. And there's actually a fascial attachment. So if we know that shockwave works for plantar fasciitis, certainly it can work for a tibial fasciitis, as Rich calls it. Again, I have the patients do eccentrics. I think proprioceptive work is very important as well. And you know, we know a lot of the risk factors. And the other thing I tell people is that multiple things will cause medial tibial stress syndrome to happen. And you need to do multiple things to try to get them better. Okay. Training errors typically is when you're going to see it. So in the high school population in September, when cross country starts, you're going to see a lot of people coming in, a lot of those kids, people who just started a training program, people who increased their training. The core muscles as well are extremely important for strengthening. This was an interesting study from a Finnish sports medicine clinic, and what they found was that 75% of all leg pain was from medial tibial stress syndrome or stress fractures. So exercise related lower leg pain is very common. And what they found was, in looking in the literature, was 24 to 35% of those involved in the military training will get exercise related lower leg pain, 12 to 15% of high school runners, and 22% of active college students. So it's something that we typically are going to see as podiatrists and as people who treat the lower extremity. And you know, the literature actually says that there's very few things that work for medial tibial stress syndrome. So a retraining program is something that's been found to work. And there's also proof that medial tibial stress syndrome responds particularly well to shockwave therapy. But there were some studies that have shown that nothing works. So this was Winters reviewing all the randomized controlled trials. No evidence for the effect that most things work, but they did conclude that shockwave appeared to have the most promise of anything that was being done. And these are some of the things that I'll have my patients do. So that's my wife, the physical therapist, demonstrating a proprioception exercise, balance on 1 foot, one foot, one leg exercises I think are very important, because anyone who's running, anyone who's active, anyone who's playing basketball, they're going to be on 1 foot a lot of the times when they're running. So working on the proprioception, working on the core muscles, especially the glutes, eccentrics. And I will typically start radial shockwave that first visit. This is not something where I'm going to tell people, let's try these things for 6 weeks, and then if you're not better, come back and get Shockwave. Start it on the first visit if you're someone that's an adopter and you utilize it. So typically what I'm going to do is 5 treatments spaced a week apart. And one of the things that I particularly like about the Zimmer M-Pulse unit is you see those blue caps that are on the tips of the applicators. So that handpiece has a metal head to it. And the metal head is a little bit more painful when you're going over a bony prominence. So when you add that plastic cap, that lowers the amount of pain that people will feel. It'll mitigate the shock slightly, but I haven't seen much of a difference. And the other thing that I typically do is titrate it up. So the lowest setting is 60 millijoules. The hertz is how many shocks there are per second. So I'll typically start at 10. If people are experiencing pain, I'll lower it sometimes. Sometimes they feel better when you raise it. I know some people will treat at 15 hertz, which makes the unit go a little faster. But I found 10 to be a good sweet spot. And typically I'm gonna try to titrate up to 120 millijoules when I'm doing the treatments. This was another study by Moan, found that 5 focused shockwave treatments with increasing energy helped runners get back to activity much faster than just a gradual return to running program. So the shockwave group got back to running at 60 days. The return to running program, gradual return to running program, and exercise group got back in 92 days. So for some of our patients, that 1 month is extremely important. If you're treating a high school athlete or a college athlete, their college season is short. They have 4 years eligibility. You don't want them to have to miss a season. If you can shave off 30 days, that's significant. So this was another study on medial tibial stress syndrome utilizing shockwave, and this was on Dutch Armed Forces, and this picture was from the actual paper. And I thought it was interesting that they had the patients hold the handpiece and direct the unit. So the one thing I would prefer that we see in this picture is that his hand is dropped more. So when I'm typically doing radial shockwave, I'm going to drop my hand and I'm going to try to get the head of that into that posterior medial border of the tibia, where that attachment is of the tibial fascia. And this is me. My hand probably could be even dropped a little bit more, but you can see that there's a little indentation where I'm pressing. So you want to press in a fair amount and kind of a tamping effect, you know, as I go down that tibia, and I'll tamp a little more on the areas where it hurts the most. And a lot of times I'll mark it with a marker or with a pen, just to show where the spots are that hurt the most. A lot of times I'll draw little arrows, you know. So I've had significant success in my practice with using it, you know. And of course, you know, it's important to do the eccentric stuff. So this is a great exercise that my wife, the physical therapist, is demonstrating. And you know, using one leg, going through the running motion, you're getting strengthening of the glutes, you're engaging the glutes, you're getting a proprioceptive effect, working on your balance, and the greater the range of motion, the harder it is. And she's a great athlete, and she used to be a gymnast, and she's even shaking a little. So that's a difficult exercise to do, but it's one of the things that I almost always add with my patients that are having any sort of medial tibial stress syndrome or most of the tendinopathies in the foot and the leg. I want to add some of that proprioception and eccentric training. Another area that I've found some success with it is on the sesamoids. So Dr. Saxena published a paper on radial sound wave, and he found that 90% of the patients got better and got back to activity that had sesamoidopathy. So this was one of my patients, that photo, and you can see that was a fracture. This was a high school football player. He had a turf toe injury that was pretty severe. And the end result, the thing that we were dealing with at the end was a fractured sesamoid. And I had put him in a cast. I offloaded him for 6 weeks, still was having pain. So he was one of the first patients about 4 or 5 years ago that I started to do sound wave and shockwave on the tibial sesamoid. And he got better from it. His sesamoid still showed what appeared to be a fracture, but his pain was gone when we were done with the treatments. And when I saw him for follow-up about 6 months later for something else, he was still pain-free in that area. So my advice is, don't be afraid to use shockwave in any part of the foot or leg. You know, I had another patient that had metatarsalgia. MRI was negative, x-rays were negative, orthotics didn't work, all these different things didn't work. I used radial shockwave on him, and he got better. You know, so I think it's something worth trying because the downside isn't there. So Rich Boucher likes to use that term six sesamoid syndrome, and I agree with it. You don't always have to see a fracture in order to have pain there. So there is significant evidence that shockwave therapy works extremely well, and there's a lot of positive studies that show it. But I think the best benefit of it is there's no downside. There's nothing negative. There's very few negative effects associated with it. You're not going to cause any damage to the patient, and typically they're going to do very well. And one of the questions I get commonly is, or statements that I'll get from people is, oh, that's great that you do shockwave. Your patients are going to pay for it. I live in an area where my patients aren't going to pay for it. I don't think that's true. I think people will pay for a treatment that works, that's going to help them get better. And a lot of times I'm seeing people that are runners that are a little desperate. They've been in pain for 6 months or a year. They can't run. They can't do the things they want to do. And they're willing to do it. And because I have the reputation of doing shockwave, I now have people calling and asking for it. So this was a great table that Dr. Saxena and I put together. We wrote a chapter on plantar fasciitis and plantar fascial problems for a book called Foot and Ankle in Sports Medicine that was written by Dr. Altchek, who's from the Hospital of Special Surgery and orthopedic surgeon for the Mets and the Yankees. And we surveyed 12 orthopedic and podiatry offices for the treatment of plantar fascia. And what we found was these were kind of some of the averages of how much people are spending. So we know now, especially even more so, that most people's insurances don't cover most things. People don't have co-pays anymore. They have co-insurances. So what I charge $100 every time I use the unit. So if I'm doing 5 treatments, it's typically $500. Some people will charge for a package and then say over the next 3 months, we'll do as many treatments as you need or as you think you desire. I think that model can work as well. Typically what I'll do is after the initial visit, if the only thing my patient is coming in for is shockwave, I tell them I'm not going to take their copay. I'm not going to bill for an office visit. It's just going to be the $100. And a lot of times people will have $40 or $60 copays, but now you've got the benefit of that $100 is going into your office right away. Your office doesn't have to chase after the insurance company for the rest of the money that they're owed, or chase after the patient after the patient pays their copay, and then they're responsible for the rest of the office visit. So I think it's something that can be very affordable. And if you think about, to pay for a $20,000 unit, if you do five treatments at $100 a treatment, you only need about 40 patients to pay for the unit. So I think it's something that is a game changer. I've actually given up doing surgery in part because shockwave has been so successful in my practice, and I haven't had to do as many surgeries. And it's a lot less stressful to do a treatment that has little downside and is actually going to make people happy and have a great effect, I think. That's our local beach here in the Clearwater area. That's Caladesi Island State Park. If you ever come visit, it's an amazing place to go. So if anybody has any questions, we're more than happy to take some.
Thank you very much for your presentation today, Dr. Fullem.
My pleasure.
I will take the screen back now. We will do question and answer a session momentarily, but I believe first Dr. Jay Spector has some comments to add about his experience with radial shockwave therapy in his practice. Dr. Spector?
Hi, my name is Jay Spector. I practice in the Atlanta area, a place called Johns Creek, and I too have a sports medicine practice. My practice's name is Atlanta Sports Podiatry, and I've included shockwave therapy, as my go-to. I just want to go over with you just in the past week what I've used it for. Dr. Fullem gave a very thorough presentation, and I just want to give you like my real life in my sports medicine world. I'm treating somebody with sesamoiditis, as he just mentioned. Treated this fella 5 treatments, but he was probably better after 2 treatments, and he just hit his personal record for half marathon. He finished in the top 15 in the Atlanta half marathon. That was last week on Thanksgiving, which was a pretty big deal. And this poor guy's been having sesamoid pain for 5 years. And probably after 2 or 3 treatments, he felt about 90% better, but was sort of paranoid about it and wanted to go through the full 5. Shin splints, treat that. I have several young runners with shin splints, plantar fasciitis. Achilles tendonitis, I just had a competitive cross-country runner, and now he's training for track for one of the local Division I universities around here. And this guy's Achilles tendon looked like the one in the picture that Dr. Fullem showed. And I saw him on Monday, and he had had 2 treatments of shockwave, and his tendon looked perfectly normal 2 weeks later. I just gave him his 3rd treatment. He's actually running totally pain-free right now. And, it's a very big deal for athletes to get back to their sport as quickly as possible. And using shockwave, there's no downtime. So you could run, that day. I've also had a run on people with peroneal problems, all runners. And I've been using it on peroneus brevis. And the advantage of this versus, say, like a cortisone, you can't do a cortisone injection along, 6 inches of a tendon. It's impossible. With shockwave, you can go along the length of the tendon, which is a huge, huge advantage. Plus, look, we have to think about efficacy. IT band, patients who get IT band, it's crippling. There's very few things that you could do that actually work outside of, ice. But the biggest thing that really works is rest, right? They rest for 6-7 weeks. They don't run. They lose a lot of time. I've been using it on IT band on, the insertion just below the knee, and patients are able to run through it and heal quicker, a lot quicker. Also had somebody with a distal hamstring tear. It's black and blue. It was a running injury. And after 2 treatments, not only did the ecchymosis go away, but patient's virtually pain-free. So again, I say 3 to 5 treatments. I charge $485 up front for anywhere from 3 to 5 treatments. And I'm in an area where I have a mixed bag of working class and upper middle class. And people, in order to get better, they're very motivated to do something that's going to work. And I really have very few problems in getting people to pay for it. And just like Dr. Fullem, when I charge them the $485, when they come back for subsequent visits, I don't charge them a copay. They just come in and they get the shockwave treatment. So if you have any questions, feel free to ask.
Yeah, if I could just add something about the payment. When I did first start using the radial unit in my office, I probably didn't charge about 50% of my patients. And when I was treating someone, say for sesamoid for the first time, I didn't charge them as well. And if I have a patient that I know has a financial problem with paying for it, then I'm not going to charge them for it. And I learned this from Ludger Gertesmeyer. Ludger practices in Germany, and he's one of the foremost researchers on shockwave. And Ludger tells his patients if they can't afford it, that he'll do the treatment for them for free. And if they get better, they can either come back and pay him what they think it's worth, or they can try to refer him a patient. So that's typically the approach I take. I don't ask them to come back and pay, because Ludger said no one ever came back and paid him. But certainly people are going to refer people to you. And what I found now that I've been in Florida for 8 years is now people are calling my office specifically asking for shockwave. So in the beginning, if you're hesitant and you're nervous about charging people and you want to get some results first, then I don't think there's anything wrong with charging an office visit when they come in and doing the shockwave. It's going to be a practice builder. And if you're using it on someone and they can't afford it, I think it's still worth it to treat them with it because it's the best treatment for the patient.
Okay, excuse me. Thank you very much, Dr. Spector, for your comments. And Dr. Fullem, we do have some excellent questions coming in here if you're ready to begin the question and answer portion of the webinar.
Sure.
Sure. Some of these you may have touched on a bit during your presentation, but maybe you can elaborate here a bit. And Dr. Spector just talked about this a bit. First question is, are steroid injections used in combination with treatment?
That's a good question. Typically, what you want to have if you're going to do a series of shock waves is you want to have a little bit of a washout period. So typically, you want to have a minimum, I think, of 2 weeks after a steroid injection before you start shockwave. I prefer even a little longer than that. But I have had patients where, I had a patient who was getting shockwave and they had a big race coming up and they still had a significant amount of pain. And so they had plantar fasciitis, and I did a cortisone shot the week before the race to help alleviate some of their pain, and they still responded to the shockwave. So I would say it's preferred not to use it, but if you have someone who has an event coming up, an important game or an important competition, then maybe the cortisone is something to think about because you are going to get a better short-term result. And we're not really sure long-term if that affects the efficacy of it or not.
Okay, this question, I believe you answered plus or minus, but maybe you can go into more detail. The question is, how many treatments are usually required?
Yeah, typically I'm doing at least 3 and most times up to 5. And then I'm going to wait about 3 months. And I've had patients come back for a second series of it and they, maybe they get 50% better or 70% better. And then I'll do another series 3 to 4 months later.
Okay, great. Here's a really good one. In treating insertional Achilles tendinosis, patients find it very painful against the bone. Do you find it effective for insertional pain, and do you consider ankle block?
I've probably only blocked about 5 people. Typically it's male, and for insertional. It works extremely well. I think the Zimmer unit has the benefit of that blue cap. That does make it more tolerable. And I've spoken about this with Ludger, and he says in Germany they just tell the patients they have to take it. But a lot of times what I'll do is I'll start at a lower level, and I'm not going to increase it. If I find that the patient can't tolerate it, I'll do that first treatment at 60 millijoules. And typically what I find is the next treatment, I'm going to be able to go a little bit higher. As they start to respond, they're going to have less pain in the area. And then you can get to your 120, which I think is a good therapeutic level.
Okay, and the next question here goes a little bit further than the last, but very similar. Do you need to block the area or use anesthesia?
Most of the time, no. So that's the only time I've ever blocked anybody is for insertional Achilles when you're treating right over a bony prominence in the heel. And I've treated medial tibial stress syndrome can be painful, but typically I'm not going to use any local anesthesia for that.
Okay. Are any of the treatments covered?
I haven't found, especially in Florida, I haven't found any insurances that pay for it.
Okay. Do you find that patients have issues paying cash?
I haven't. No, not at all.
No issues.
No.
Okay. Here's another one. Have you used it for neuromas, plantar fibromas, or tarsal tunnel, and what has been your success?
Almost no success with neuromas. No success with tarsal tunnel. In fact, I'm not sure if it's even a good idea for tarsal tunnel to even try it. The literature doesn't support it in the tarsal tunnel, certainly. In fibromas, I have used it. Kind of mixed success with fibromas, but in theory it should work because when you get new blood vessels and that neovascularization, it should help reorganize that fibroma. So fibromas definitely. The other two, not so much.
Okay. Okay, here's a question. What is the average success rate you see?
The literature shows, above 70% for most problems in the lower extremity. So, and it's interesting, I would actually say the plantar fascia is my least successful spot. So I think I'm probably in the 70 to 80% range with plantar fascia, and I think higher than 80% for most other things. And one of the things that I found now is if people aren't responding to my treatment with Shockwave and with the other things we're doing, that maybe there's something else going on. And what I found a few times, particularly with heel pain, is people had a plantar fascia tear or they had a calcaneal stress fracture and they needed to go into a boot. But the good news about that is when you diagnose it and you immobilize them for a short time, the Shockwave is still going to help them heal. But that's typically where I'm going to find where I'm failing is if I'm not 100% accurate in my diagnosis. But I would say the majority of the time, about 80% of my patients are seeing significant improvement.
We really have a lot of questions rolling in here. I apologize. We're running a few minutes over. If you don't mind taking a few more questions, we can get to. Wonderful. Okay, next question is, what setting do you begin for insertional Achilles tendinosis and retrocalcaneal bursitis?
I start at the lowest, which with the Zimmer impulse unit is 60. And sometimes, like I said before, I do not go above that. If they can't tolerate it, if they're having a hard time tolerating it, then I'm not going to go above it. And the one thing that I'll typically do with that insertional is I will move the handpiece around. So there are typically going to be certain spots that are much more painful. So I'm just not leaving it on that spot. I'm moving it around, treating the whole area, which is that neovascularization is going to help that whole area. And then, when you go over that painful spot, they're going to flinch a little bit, and you just don't leave it there too long.
Okay, this next question, I believe you answered part A during your presentation, but there is a part B. Is there any downtime? Can patients resume daily activities right away?
I think for most things, I have no problem at all. But I would caution people that are treating mid-substance Achilles where they're at risk for a rupture, because sometimes I'll do the treatment and people will get immediate pain relief. I think that's the depletion of substance P. And the tendon is still, diseased and still has some degeneration in it in the early stages. And you got to caution your patients not to do too much. So most of the time, I'm going to tell them, sure, you can go run today if you want, as long as you're not limping. But with the Achilles, I'm a little more cautious.
Okay, just a couple more questions here that we have time for today. Posterior tibial tendon tears or tendonitis with swelling? Question mark?
Yeah, I think it works extremely well for posterior tibial tendinopathy. With a tear, it certainly makes sense that it may help, but I'm not sure you're going to get as much of a desired result. Depends on the tear. If you're dealing with a stage 3 PT tendon dysfunction, I don't know how effective Shockwave is going to be for that.
Okay, let's do one more question here. Someone wants to know, are you treating acute fractures?
Not with a radial unit.
Okay, wonderful. Well, thank you very much for that discussion, Dr. Fullem.
Sure.
Thank you very much. If anyone would like more information about the nPulse Pro, please visit Zimmer MedizinSystems website at www.zimmerusa.com, and be sure to visit the section of the website that is dedicated to providing information about radial shockwave therapy in podiatry. This can be accessed through the website's main navigation menu. Zimmer MedizinSystems also has an assortment of podiatry waiting room materials available for you to browse on the shopping site at shop.zimmerusa.com. And that concludes today's webinar. Thank you very much for attending. A recorded version of this webinar will be emailed to all attendees so that you may review any of this information at your leisure. Good night.